Patients with clinical conditions frequently develop acid-base imbalances. Always consider the possibility of an acid-base imbalance in patients with serious diseases. The body normally maintains a steady balance between acids continually produced during normal metabolism and bases that neutralize and promote the excretion of acid. The acidity or alkalinity of a solution depends on its hydrogen ion concentration. An increase in hydrogen concentration leads to acidity, and a decrease leads to alkalinity. In a healthy state, a ratio of 1 part carbonic acid to 20 parts bicarbonate provides a normal serum pH of 7.35 and 7.45. Any deviation to the left of 7.35 results in acidotic state. Any deviation to the right of 7.45 results in alkalosis. Because the normal metabolic process produces acids, the body must neutralize and excrete them in order to maintain a normal balance between acids and bases. The body has 3 mechanisms by which it regulates the acid-base balance to maintain that normal arterial pH between 7.35 and 7.45. Those mechanisms are the buffer systems, the respiratory systems, and the renal system. The regulatory mechanisms react at different speeds. Buffers react immediately. The respiratory system responds in minutes and reaches maximum effectiveness in hours. The renal response takes 2 to 3 days to respond maximally, but the kidneys can maintain a balance indefinitely in chronic imbalances. So buffers act chemically to change strong acids into weaker acids or to bind acids to neutralize their effect. This minimizes the effect of acids on blood pH until their excretion from the body. When released into circulation, carbon dioxide enters the red blood cells and combines with water to form H2CO3. This carbonic acid dissociates into hydrogen ions and bicarbonate. The free hydrogen is buffered by hemoglobin molecules, and the bicarbonate diffuses into the plasma into the pulmonary capillaries. This process is reversed, and CO2 is formed and excreted by the lungs. The respiratory center in the medulla, in the brainstem, controls the rate of excretion of CO2. If increased amounts of CO2 or hydrogen ions are present, the respiratory system stimulates an increased rate and a deep breath of breathing. If the center senses a low hydrogen ion or CO2 levels, respirations are inhibited. As a compensatory mechanism, the respiratory system acts on the CO2 and H2O side of the reaction by altering the rate and depth of breathing to blow off the CO2 through hyperventilation or to retain CO2 through hypoventilation. If a respiratory problem is the cause of an acid-base imbalance, such as respiratory failure, the respiratory system loses its ability to correct the pH alteration. The older adult has an impaired compensatory ability because of decreased respiratory function. Under normal conditions, the body depends on kidneys to absorb and conserve all the bicarbonate they filter, and to excrete a portion of the acid produced by cellular metabolism. The three mechanisms of acid elimination are the secretions of small amounts of free hydrogen in the renal tubular, the combination of hydrogen with ammonia to form ammonium, and excretion of weak acids. Or to compensate for acidosis, the kidneys can generate additional bicarbonate and eliminate the excess hydrogen ions. This increases the blood pH and decreases the urine pH. If the renal system is the cause of an acid-base imbalance, such as renal failure, it loses its ability to correct the pH alteration. This figure demonstrates the interrelationship among the lungs, the kidneys, and the buffer systems, in this case, the red blood cells, in the maintenance of an acid-base balance. The lungs control gas exchange to blow off or retain CO2. The CO2 is generated in tissues, is transported in plasma as bicarbonate. The erythrocyte hemoglobin also contributes to the CO2 transport. Hemoglobin buffers hydrogen ion derived from carbonic acid. The kidneys reabsorb filtered bicarbonate in the proximal tubulars and generate a new bicarbonate in the distal tubulars, where there is a net secretion of hydrogen ion. Ultimate balance between bicarbonate and carbonate acid is to maintain a pH within normal limits. Here's a cartoon depicting alkalosis, acidosis, and you can see that if the pH is greater than 7.5, you have alkalosis, and if the pH is less than 7.45, you have acidosis. An acid-base imbalance results when there's an alteration in the ratio of 20:1 between base and acid content. This occurs when a disease or process alters one side of the ratio, such as CO2 retention in pulmonary disease, and the compensatory process that maintains the other side of the ratio, an increased renal bicarbonate reabsorption, either fail or they're inadequate. The compensatory process may be inadequate because of the pathological process is overwhelming, or there's not enough time for the compensatory process to function. Acid-base imbalances are classified as either respiratory or metabolic. Respiratory imbalances result from the retention or an excess of carbon dioxide altering the carbonic acid concentrations. Metabolic imbalances affect the base bicarbonate. Acidosis occurs when there's an increase in carbonic acid, which is respiratory acidosis, or a decrease in bicarbonate, which is metabolic acidosis. Alkalosis occurs when there's a decrease in carbonic acid, which results in respiratory alkalosis, or an increase in bicarbonate, which results in metabolic alkalosis. Imbalances are further classified as acute or chronic. Chronic imbalances allow a greater time for compensatory changes. Acidosis can be caused by an excess of carbonic acid, which is respiratory, or a decrease in bicarbonate, which is metabolic. Alkalosis can be caused by a decrease in carbonic acid, which is respiratory, or an increase in bicarbonate, which is metabolic. Respiratory imbalances caused by carbonic excess, or acidosis, and carbonic acid deficit, which is alkalosis. Metabolic imbalances caused by bicarbonate deficit is acidosis, and metabolic imbalances caused by bicarbonate excess is metabolic alkalosis. So arterial blood gases are going to provide objective information about a patient's acid-base status, the underlying cause of an imbalance, the body's ability to regulate the pH, and the patient's overall oxygen status. Knowledge of the patient's clinical situation and the physiologic extent of the renal and respiratory compensation allows you to identify an acid-base disorder as well as the patient's ability to compensate. Blood gas analysis can also show the partial pressure of arterial oxygen, which is the PaO2 on a blood gas, and the oxygen saturation, which is the monitored on a pulse ox. These values help you evaluate the patient's overall oxygenation and identify hypoxemia. To interpret the results of an ABG, perform the following steps. Look at each of the values. If the pH is between 7.35 and 7.45, and the CO2 and the bicarbonate and PaO2 oxygen level is all within normal, the ABGs are normal. If any value is out of normal, then you need to continue. You have to determine if the pH is acidotic or alkalotic. So by looking at the pH, you're going to see whether or not it is alkalotic or acidosis. If you have a pH less than 7.35, you're acidotic. If you have a pH greater than 7.45, you're alkalotic. When you look at a blood gas, you can look at this pH and you're able to see the first and last name of this blood gas. Because if you have a pH that is between 7.35 and 7.45, your blood gas is compensated. If the value is less than 7.35 and greater than 7.45, it's uncompensated. So now you have, knowing whether it's compensated or uncompensated, you've got the first name of this blood gas. So it's either going to be compensated when the values are normal, or it's going to be uncompensated if it's not between 7.35 and 7.45. If the value is less than 7.35, it's acidotic. So here you have, just looking at the pH, you know whether or not it's compensated or uncompensated, and whether it's acidotic or alkalotic. So you're going to determine the cause. So what you're going to do next then is analyze the CO2 to see if the patient has respiratory acidosis or alkalosis. Since the lungs control the PaCO2, it's going to be the respiratory component of the blood gas. Because the CO2 forms carbonic acid when dissolved in blood, the high level of PaCO2 levels decrease the pH and indicate respiratory acidosis. Low CO2 values increase the pH, and that would indicate respiratory alkalosis. If the pH moves in the appropriate direction for this PaCO2 to change, such as a pH lowered with an increase in the CO2, or the pH higher with a decrease in CO2, then it is a respiratory problem. That would be the primary disturbance. Next, you're going to analyze the bicarbonate to see if the patient has metabolic acidosis or alkalosis. Since the kidneys primarily control the bicarbonate, it is a metabolic component of the ABG. Because the bicarbonate is a base, high levels of base increase the pH and result in metabolic alkalosis. Low levels of pH decrease the pH and result in metabolic acidosis. If the pH value moves in the appropriate direction for the change, such as with metabolic acidosis and alkalosis, you're either going to have, they're both going to go in the same direction. You're going to have a low pH with a low bicarbonate level, or you're going to have a high pH with a high bicarb level. And that would indicate a metabolic primary disturbances. So you can see with metabolic, the changes are going to go both in the same direction. They're both either going to be low or they're both going to be high. And that's opposite of what happens in a respiratory disturbance when you have the pH being high and the carbon dioxide being low, or the pH being low and the CO2 being high. So determining whether they're compensating or a mixed disturbance is present, you have to look at both the component of the CO2 and the bicarb that is not the cause of the primary disturbance. If the component that does not match the pH is moving in the opposite direction, the body is attempting to compensate. For example, if the pH is slightly acidotic and the CO2 is high, your pH being like 7.33 and the CO2 is 55, and the bicarbonate is high, like 36, then the CO2 is the parameter that matches the acidotic pH. The patient's underlying acid-base imbalance is respiratory acidosis. The bicarbonate level is alkalotic. Since this is in the opposite direction of respiratory acidosis, there is compensation that's occurring. If both parameters match the pH, consider the possibility that there's a combined disturbance of both metabolic or respiratory acidosis or alkalosis. For example, if you have a pH of 7.28, which is acidotic, and the CO2 is high, say 55, and the bicarb is low of 16, then the patient's underlying acid-base imbalance is a combined respiratory and metabolic acidosis. Next, you want to determine the oxygen saturation in the arterial blood, the PaO2, and the O2 saturation on the pulse oximeter to see whether or not hypoxemia is present. Just another reminder, the symptoms of hypoxia. Early symptoms of hypoxia, think of this rat: restlessness, anxiety, tachycardia, tachypnea. That's when you want to intervene with your patient. When they're restless and anxious and tachycardic and tachypneic, do something early, because what happens in late hypoxia? They're going to have bradycardia, extreme restlessness, and dyspnea. Eventually, they're going to stop breathing on you. So you want to intervene early. So this is a picture from your book of normal blood gases. So it's good to keep them on a note card and refer to them often until they become ingrained in your memory. So pH, normal pH is 7.35 to 7.45. The good part about knowing these values, when we talk about a carbon dioxide, they're the same numbers, 35 to 45. So that is a normal. And the bicarbonate, think of the numbers, ages that everybody wants to be, between 22 and 26. And when we're looking at a blood gas, the oxygen concentration should be 80 to 100. And when we're looking at someone's pulse ox, that level should be greater than 95%. So this is a good mnemonic to remember. Think of Rome. So like we said before, if you have respiratory alkalosis, the arrows are going to be pointing in opposite direction. Alkalosis, the pH is going to be high and the CO2 is going to be low. Respiratory acidosis, the pH is going to be low and the CO2 is going to be high. And metabolic, think of M for marriage. People married going to be in the same direction, hopefully. So acidosis is metabolic acidosis means the pH is low and the bicarb is low. Metabolic alkalosis means the pH is high and the CO2 is high. Just another reminder, this is help you to understand these concepts. Again, so looking at the analysis of a blood gas, they look at your pH and determine whether it's compensated or uncompensated. If it's compensated, it's going to be within normal of between 7.35 and 7.45. And then look to see whether it's acidotic or alkalosis. So you can have the first and last name of this blood gas, and then you have to find out who the daddy is, who is causing this disturbance, Mr. Respiratory or Mr. Metabolic. And so here we have a pH of 7.30. And so this is less than 7.35. It indicates acidosis. We have a CO2 of 30. And this is alkalosis, right? And we have a bicarb of 16, and this indicates metabolic acidosis. So the bicarb matches the pH. So it indicates that this is metabolic acidosis is the primary problem. The CO2 is moving in the opposite direction, and that indicates the lungs are attempting to compensate for the metabolic acidosis. The PaO2 is normal, so this patient does not have hypoxemia. So when you look at this blood gas of 7.30, 30 for the CO2, 16 for the bicarb, and 95 for the oxygen level, the blood gas then is interpreted as metabolic acidosis with partial compensation. So causes of acidosis. Acidosis is when you're going to have a pH of less than 7.4. So hypoventilation, you're going to find somebody that's acidotic is not going to be breathing. They're going to be a few steps over from needing mechanical ventilation. Their pH is going to be low. They're going to be retaining CO2. They could have an airway obstruction. They could have a drug overdose. They could be in pulmonary edema. That would be causes of respiratory acidosis. On the other hand, if you have metabolic acidosis, so these arrows are both going to be going in the same direction, downward, the pH is going to be low, the bicarb is going to be low. You could have a patient that has had a aspirin overdose, has diabetic ketoacidosis, that's going into shock, that is in renal failure, or has severe diarrhea. Another good thing to remember is that you lose base from your butt. So when you have diarrhea, you're losing a bunch of base. And when you lose your base, all you have left is acid. So you end up with acidosis. You lose base from your butt and acid from your gut. So respiratory acidosis is carbonic acid excess. This occurs when there's hypoventilation. Hypoventilation results in the buildup of CO2, which results in an increase of carbonic acid in the blood. Carbonic acid dissociates, liberates the hydrogen ions, and there's a decrease in the pH. If the CO2 is not eliminated from the blood, acidosis results from the accumulation of carbonic acid. To compensate, the kidneys conserve bicarbonate and secrete increased concentrations of hydrogen ion into the urine. During respiratory acidosis, the renal compensatory mechanisms begin to operate within 24 hours. Until those renal mechanisms have an effect, the serum bicarbonate will usually be normal. Here we have a picture of respiratory acidosis. So this is someone that has hypoventilation leading to hypoxia. They're going to have rapid shallow respirations, a lower blood pressure. Their skin mucosa is going to be pale and cyanotic. They may have a headache. They might have an elevated calcium or potassium. And because of that high potassium, they could be at risk for throwing arrhythmias, sometimes fatal arrhythmias. They would be drowsy, dizzy, disoriented, have muscle weakness, hyperreflexia. And some of the causes of respiratory acidosis: respiratory depression related to anesthesia, drug overdoses, increased intracranial pressure, an airway obstruction, alveolar decreased capillary diffusions, which you would see in pneumonia and COPD, acute respiratory distress syndromes, and pulmonary embolisms. To compensate for metabolic acidosis, the kidneys attempt to excrete additional acid and lungs to increase the CO2. So metabolic acidosis, the kidneys attempt to excrete additional acid and the lungs increase CO2 excretion. The patient then develops what we call Kussmaul respirations, which are deep, rapid breathing. If metabolic acidosis is present, calculating the anion gap can help determine the source of metabolic acidosis. That anion gap is the difference between the measured serum cations and anions in the ECF. You can calculate the anion gap by using the formula of sodium minus the bicarb plus the chloride. And that normal gap is 8 to 12 millimoles. The anion gap is going to increase in metabolic acidosis. It's associated with an acid gain. So lactic acidosis, diabetic ketoacidosis, this occurs in. But in normal metabolic acidosis caused by like diarrhea, it's going to be normal. So you're going to see patients that come in with metabolic acidosis and diabetics, and until that gap is closed, they're going to have to be on an insulin drip. So here's a picture to help you remember metabolic acidosis. So what we have here then is there is too much of bicarb. The patient has, there's in metabolic acidosis, we have patients with a headache, a low blood pressure, hypokalemia, elevated potassium. Their muscle tone and reflexes are going to be decreased. They're going to have this Kussmaul respirations. It's compensatory mechanisms. And so some of the causes then is going to be the increased bicarbonate production. So we have DKA as a cause. We could have poor bicarbonate elimination, so that could be from renal failure. We could have patients with dehydration or liver failure, or we could have someone with problems with elimination, so patients that have fistulas or diarrhea. So you're going to have a patient with nausea and vomiting, and a flushed skin and muscle twitching. So causes of metabolic alkalosis. So respiratory-wise, this is going to be someone that has a high pH and a low CO2. Causes of the alkalosis. So anxiety, sometimes due to elevation, high altitudes. This could be happening in the initial stages of pulmonary problems, and also can occur with mechanical ventilation. So alkalosis is a pH greater than 7.45. And if you have metabolic conditions, then the pH is going to be high and the bicarb is also going to be high. So it could be overuse of bicarbonate, patients that are taking diuretics, or a loss of gastric juices. So remember I said you lose base from your butt, you lose acid from your gut. So you lose all your acid and you end up with alkalosis. So respiratory alkalosis is a carbonic acid deficit that occurs with hyperventilation or an increase in respiratory rate or volume. So the primary causes of respiratory alkalosis is hypoxemia from acute pulmonary disorders. Hyperventilation can occur as a physiological response to metabolic acidosis and increased metabolic demands, such as fever, pain, anxiety. They can increase respirations without a physiological need. Pain, anxiety, and central nervous system disorders can increase the ventilation rate. The hyperventilation is going to blow off CO2, leading to a decreased carbonic acid concentration in the blood and an increased pH. Compensated respiratory alkalosis is rare. In acute respiratory alkalosis, aggressive treatment of the causes of hypoxemia is essential and usually does not allow time for compensation to occur. Some buffering can occur with the shifting of bicarbonate into the cells in exchange for chloride. In chronic respiratory alkalosis that occurs with pulmonary fibrosis, compensation may include renal excretion of bicarbonate. So here we have a picture of depicting respiratory alkalosis. So the pH is going to be high and the CO2 is going to be low. Signs, hyperventilation, increased rate and increased depth. You'll have tachycardia. Blood pressure would be decreased. You'll have a low potassium. You may have numbness and tingling in the extremities. You could have hyperreflexes and muscle cramps, potential of seizures, increased anxiety and irritability. So some of the causes: hyperventilation, anxiety, a PE, a pulmonary embolism, fear, or mechanical ventilation. Metabolic alkalosis, which means there's a base bicarbonate excess, occurs when there's a loss of acid, so prolonged vomiting or gastric suction, or a gain in bicarbonate, such as the ingestion of baking soda. So the renal excretion of bicarbonate occurs in response to metabolic alkalosis. The lungs' compensatory response is limited. The respiratory rate decreases in order to increase plasma CO2. However, once hypoxemia occurs or plasma CO2 reaches a certain level, the stimulation of chemoreceptors increases respirations. So here's another picture of metabolic acidosis. You can see that you have a increase in pH and an increase in bicarb. which is causing the metabolic acidosis. So you have confusion, dysrhythmias, tachycardia from either way, potassium. It should be in normal, otherwise it's going to affect your heart rate. And you could have compensatory hypoventilation with metabolic acidosis. So some of the causes, taking antacids, administration of sodium bicarbonate, or NJ suctioning, prolonged vomiting. Some of the symptoms then: anxiety, seizures, tremors, muscle cramps, tingling in the muscles in the fingers and toes, always looking out for a low serum calcium, dizziness, irritability, nausea, vomiting, and diarrhea.